Hello and welcome to Chronic Pain Tips for Patients, the podcast where we talk about chronic pain in a clear, practical, and patient-centered way. I'm Dr. Yuri Martins, an interventional pain physician in St. Louis, Missouri, and southern Illinois areas. And today I want to talk about a condition that many patients and sometimes even clinicians may not immediately think about when evaluating low back and buttock pain. The condition is called superior cluneal neuralgia. Now, this is not a term most people ever heard. Many patients are familiar with sciatica, herniated discs, spinal arthritis, and sacroiliac joint pain. But superior cluneal neuralgia can sometimes mimic those conditions. It can cause pain in the low back, upper buttock, hip region, and sometimes even pain that seems to travel towards the leg. Because of that, it can be missed. And when a pain generator is missed, patients may go through treatments that do not fully address the real source of their pain. So, in today's episode, we will discuss what the superior cluneal nerves are, why they can cause pain, how this condition is diagnosed, and what treatment options may be considered. So let's start with anatomy. The superior cluneal nerves are small sensory nerves. Their job is to provide sensation to the skin over the upper buttock region. These nerves come from branches of the spinal nerves in the lower thoracic and lumbar spine. They travel across the back of the pelvis and pass over the top of the pelvic bone, which is called the iliac crest. You can think of the iliac crest as the upper ring of the pelvis. This means the bony ridge you may feel if you place your hands on your hips or upper buttock area. As the superior cluneal nerve crosses this area, they may pass through a tight space formed by connective tissue and bone. This space can behave almost like a tunnel. And just like other nerve entrapment conditions, if the nerve becomes compressed, stretched, kinked, or even irritated in that tunnel, it can start sending pain signals. That's one of the main mechanisms behind superior cluneal neuralgia. One of the challenges with this condition is that it does not always look unique at first. Patients may come with low back pain. They may say the pain is in the upper buttock. Some may report pain that travels towards the hip or leg. And that can sound like sciatica. It can sound like sacroiliac joint pain. It can sound like facet joint arthritis, and in some patients, those diagnoses may be correct. But in others, the problem may be this small sensory nerve crossing the iliac crest. Another reason this diagnosis can be missed is that the superior cluneal nerve usually does not show up clearly on routine spine imaging. But those findings may or may not be the true source of the patient's pain. This is an important point. Imaging can be helpful, but imaging does not always tell the full story. Many people have findings on MRI that are not causing their symptoms. And besides that, a true diagnosis in chronic pain is done by combining the history, physical examination, imaging when appropriate, and sometimes diagnostic injections. Superior cluneal neuralgia is one of those conditions, where the physical examination and response to a diagnostic block can be very important. Patients with superior cluneal neuralgia often describe pain in the low back or upper buttock area. The pain may feel deep, aching, burning, or difficult to localize. It may stay near the top of the pelvis, or it may spread towards the buttock, hip, or leg. Some patients notice that their pain gets worse when standing, walking, or extending the lower back. In some cases, the pain pattern resembles sciatica, even though it's not coming from compression of a spinal nerve root. This is sometimes called pseudosciatica. Pseudo means fake. One of the most important clues is a tender point near the iliac crest. When the physician presses over that spot, it may reproduce the patient's usual pain. This tender point is sometimes called the iliac crest point sign. Now, there is another important distinction. The lumbar radiculopathy, what many people call a pinched nerve in the spine or sciatica, may cause pain, numbness, tingling, weakness, or changes in reflexes in a specific nerve root pattern. Superior cluneal neuralgia is different. Because the superior cluneal nerve is a sensory nerve, It usually does not cause muscle weakness, it usually does not cause loss of reflexes, and the sensory symptoms do not always follow a classic dermatomal pattern. So, if someone has pain that travels but does not behave exactly like a typical pinched spinal nerve, superior cluneal neuralgia may be one of the conditions to consider. So, how do we diagnose superior cluneal neuralgia? Superior cluneal neuralgia is mainly a clinical diagnosis. That means it's based on the patient's symptoms, the location of the pain, the physical examination, and sometimes the response to a diagnostic injection. A typical diagnostic pattern includes three things. First, the patient has low back or buttock pain, sometimes with radiation towards the hip or leg. Second, there's a tender point near the iliac crest that reproduces the patient's typical pain. Third, the patient has significant pain relief after an injection of local anesthetic around the superior cluneal nerve. In most pain practices, at least 50% pain relief after the diagnostic block is considered supportive of the diagnosis. This does not mean that every patient with low back pain needs this injection. But when the history and physical examination suggests involvement of the superior cluneal nerve, a diagnostic block can be very helpful. So, what is a superior cluneal nerve block? A superior cluneal nerve block is a procedure where a small amount of local anesthetic is injected near the area where the superior cluneal nerve travels over the iliac crest. Sometimes, a corticosteroid is also used, depending on the patient's condition and the physician's judgment. The block can serve two purposes. It can be diagnostic, meaning it helps confirm whether the nerve is contributing to the pain. It can also be therapeutic, meaning it may provide pain relief that lasts beyond the numbing medication, especially if local inflammation around the nerve is part of the problem. The procedure is usually performed with the patient lying comfortably, often face down or slightly turned, depending on the approach. The skin is cleaned carefully. Local anesthetic is used to numb the skin. Then the physician places a small needle near the target area. Ultrasound guidance may be used to improve accuracy and to help visualize nearby tissues and blood vessels. The same can be said for fluoroscopy or X-ray guidance. So what are the risks of a superior cluneal nerve block? Superior cluneal nerve blocks are generally considered low-risk procedures, but no procedure is completely risk-free. Possible risks include temporary soreness where the injection was done, bruising, bleeding, or a small hematoma. Infection is rare, but it's possible with any injection. Some patients may notice temporary numbness, tingling, or altered sensation in the buttock region after the block. There is also the possibility that the block does not help. This can happen if the superior cluneal nerve is not the main pain generator, or if the nerve anatomy is different and the medication does not reach the most relevant branch. Nerve injury is possible with any nerve block, although it is very uncommon. Local anesthetic toxicity is also very rare, especially because these procedures usually very small amounts of medication, but it can occur if local anesthetic enters the bloodstream in significant amounts. Allergic reactions are possible, but uncommon. If corticosteroid is used, additional risks may include temporary elevation in blood sugars, local tissue thinning, skin color change, or other steroid-related effects. This is especially important for patients with diabetes or other medical conditions. These risks should be discussed with the treating physician before the procedure. What happens if the block helps but the pain comes back? This is a common and very important question. If a superior cluneal nerve block gives significant relief, but the pain later returns, that does not necessarily mean the block failed. It may actually provide useful diagnostic information. It suggests that the superior cluneal nerve is likely playing an important role in the pain. In that situation, additional treatment options may be considered. They may include repeat nerve blocks, radiofrequency ablation, peripheral nerve stimulation, or, in selected cases, surgical decompression. The right option depends on the patient's symptoms, examination, medical history, goals, and response to previous treatments. So, what is a radiofrequency ablation for the superior cluneal neuralgia? Radiofrequency ablation, often called RFA, is a procedure that uses heat generated by radiofrequency energy to reduce pain signaling from a targeted nerve. So for superior cluneal neuralgia, RFA may be considered when a diagnostic block suggests that superior cluneal nerve is an important source for the pain, but the pain returns after temporary relief. As with other procedures, RFA has risks. This may include soreness, bruising, bleeding, infection, temporary numbness, nerve irritation, failure to relieve pain, or recurrence of pain over time. Because the superior cluneal nerve is sensory, the main expected effect is a change in pain or sensation, not weakness. The evidence for RFA in superior cluneal neuralgia is still developing. Early studies suggest that some patients may experience meaningful relief, but larger and better studies are still needed. What about peripheral nerve stimulation? Another option for selected patients is peripheral nerve stimulation. Treatment involves placing a small lead near the target nerve. The device delivers gentle electrical stimulation with the goal of changing how pain signals are processed. Peripheral nerve stimulation is usually considered when more conservative treatments have not provided adequate relief and when diagnostic information supports the superior cluneal nerve as a major pain generator. This is an evolving area in pain medicine. Early results are promising, but patient selection is very important. Not every patient with low back pain is a candidate. The diagnosis needs to make sense and the treatment plan needs to be individualized. So let's talk a little bit about surgical decompression. In selected cases, surgery may be considered to release or decompress the superior cluneal nerve. This is usually not the first step. It is more often considered when the diagnosis is clear and less invasive treatments have not provided adequate relief. The goal of surgical decompression is to free the nerve from the tight tissue or tunnel that is compressing it. Some surgical reports show improvement in pain and function after decompression. However, the overall evidence base remains limited. There is also an important point I discuss with patients. Nerve tissue can be difficult to heal. Even when a surgeon successfully decompresses a nerve, the nerve may already have been irritated or damaged for a long time. In some patients, the nerve may not fully recover or become a completely normal nerve ever again. In those cases, pain may persist even if the surgery was technically successful. That does not mean surgery never helps. It means expectations need to be realistic and the decision should be made carefully. So why this diagnosis matters? Superior cluneal neuralgia matters because it's a potentially treatable cause of chronic low back and buttock pain. Many patients spend months or years searching for an explanation. Some have tried physical therapy, medications, injections, or even surgery without adequate relief. When the true pain generator is a small sensory nerve near the iliac crest, treatments directed only at discs, joints, or the sacroiliac joint may not work well. Identifying the correct source of pain allows the treatment plan to become more precise. This does not mean every case of low back pain is superior cluneal neuralgia. It is only one possible diagnosis among many, but it is an important diagnosis to consider, especially when the pain is near the posterior iliac crest. There is a clear tender point and the symptoms do not fit neatly into other common diagnoses. So when should patients ask about this? You may want to ask your pain physician about superior cluneal neuralgia if you have chronic low back pain or upper buttock pain and any of the following apply. The pain is tender over the top of the pelvis or upper buttock. Pressing over one specific point reproduces your usual pain. You have been told the pain may be sciatica, but you do not have weakness or clear nerve root symptoms. Your imaging does not fully explain your pain. Treatments for other suspected causes have not helped as expected. Of course, the goal is not for you to self-diagnose. The goal is to have a careful evaluation and make sure this frequently overlooked condition is considered when the clinical picture fits. So, just a couple of final thoughts. Superior cluneal neuralgia is a small nerve problem that can create a big pain burden. It can mimic sciatica, sacroiliac joint pain, or arthritis in the spine. Because of that, it's easy to miss. The good news is that a careful examination and a diagnostic nerve block can help identify the condition. For the right patient, treatments such as nerve blocks, radiofrequency ablation, peripheral nerve stimulation, or surgical decompression may provide meaningful relief. Chronic low back pain is not one diagnosis. It is a symptom with many possible causes. Finding the right pain generator is often the first step toward finding the right treatment. Thank you for listening to Chronic Pain Tips for Patients. If you have chronic low back pain or upper buttock pain that has not improved with standard treatments, superior cluneal neuralgia may be one of the conditions worth discussing with your pain physician. To learn more about chronic pain conditions and treatment options, you can visit my website at www.ycmartins.com. You can also call my clinic to schedule an evaluation and discuss whether a personalized pain treatment plan may be appropriate for you. Until next time, I'm Dr. Yuri Martins. Thank you for listening, and I hope this episode helps you better understand your pain and your options.